Dear ladies and gentlemen, my name is William Hotomo from St.Carolus Borromeus Hospital, Kupang, Indonesia. It is a very great honor for me to present our case report about Neurocysticercosis in 15-year-old girl in East Nusa Tenggara, Indonesia. Now I will begin my presentation. Today I will present a case report of Neurocysticercosis in 15-year-old girl in East Nusa Tenggara, Indonesia. As we know, Neurocysticercosis or NCC is an acquired parasitic infection of the central nervous system, CNS, in humans, caused by encysted larva of Taenia solium. NCC has been known as a neglected and preventable cause of serious neurological symptoms in developing countries. It shows an essential etiology of seizure among children in endemic countries. And the clinical manifestation of NCC is varied greatly, which is influenced by the location and amount of lesions in CNS, parasite biological status, and host inflammatory status. Hence, the disease severity could be from an asymptomatic to symptomatic stage, such as epilepsy, arachnoiditis, cognitive disturbance, visual loss, and hydrocephalus, and so on. But epilepsy has been known to be the most prevalent manifestation of NCC. On the clinical grounds, it is a great challenge for the clinician for diagnosing NCC, as it does not have any classic clinical manifestation. That's why neuroimaging, such as CT scan and magnetic resonance imaging (MRI), has been known to be the fundamental investigations in order to make the diagnosis of NCC. In this case report, we will present Miss R, female, born December 28, 2004, who live in Waingapu, Central Sumba, and now in senior high school. And this history taking by auto and allo anamnesis. The date of admission is May 11, 2020. The patient came to our emergency ward by a focal seizure of the right hand since 10 hours before admission. The patient was referred from Waingapu Hospital with a diagnosis of space-occupying lesion at the brain. The seizure was the first unprovoked seizure she experienced in her life, with clonic movement at the right hand, along with a decrease of consciousness. The duration of the seizure was less than 5 minutes. It recurred for 3 times since 10 hours before admission to hospital. There was no report of previous seizure before. And when seizure occurred, the patient did not suffer any fever, and the history of fever before the seizure also denied. She did not have any cough. She had a record of eating pork in the rural region of Sumba Island. Poor hygiene and sanitation have been reported among the rural region in Sumba Island. For the past medical history, the patient did not have any contact with tuberculosis patient, and there's no medication history or surgical history, any hospitalization denied, and the patient did not have any allergies. For the family history, patient's parents are in good health as well as her sibling. There was no history of seizure among her family. And the social history, patient lives with her family, she studies in senior high school and does not use tobacco, alcohol, or illicit drugs. Now review of system. From the constitutional system, the patient was alert consciousness but with a little bit fatigue. From eyes, there's no changes in vision, no pain, no redness, no diplopia. From the ear, nose, throat, ear, no recent hearing loss, no tinnitus. From the nose, no sinus congestion, no epistaxis. Throat, there's no hoarseness, no sore throat, no bleeding gums, no dysphagia. For skin, no rashes, no bruising, no sores, no dryness or color changes. From the cardiovascular, there's no chest pain, no heart palpitations. For the pulmonary, there's no cough, no short of breath. And gastrointestinal, there's no nausea, no vomiting, no diarrhea, no constipation, and no abdominal pain. From the genitourinary, there's no incontinence, no frequency, no urgency, no dysuria or hematuria. From the musculoskeletal, there's no changes in strength, there's no stiffness, no ache, no joint tenderness. But in neurologic, there was a focal seizure at the right hand with clonic movement, along with decrease of consciousness, recurred 3 times since 10 hours before admission. And the psychology, there is no changes in mood, no depression, and no insomnia. Now we move to physical examination. For the vital sign, the patient's temperature 36.9 degrees Celsius and the pulse rate 97 times per minute regular, and the respiratory rate 20 times per minute, blood pressure 111 per 70 mm Hg. For the oxygen saturation, 99% in the room air, and her general condition, no apparent distress and alert during interview. Eyes, sclera and conjunctiva clear, extraocular movement intact, pupil equal, round, reactive to light, accommodate to distance, no ptosis, and the ENT, no nasal discharge, oropharynx clear without any lesions, skin no rashes, skin warm and dry, no erythematous areas. From the cardiovascular, regular rate and rhythm with normal S1 and S2, no jugular vein distension, and pulmonary, vesicular breath sound, no crackles, no rhonchi, no wheezes, good air movement. GIT, normal active bowel sounds, non-tender, no distension, liver and spleen were not palpable. Genitourinary not performed since complaints not related. And musculoskeletal, 5+ strength, normal range of motion, no swollen joints. And the neurologic cranial nerves 2 to 12 grossly intact. Normal sensation, normal physiologic reflex, and no pathologic reflex. From the hematologic test, we could find that there's increase of eosinophil and monocyte and decrease of lymphocyte. CT scan, which done at 12 May 2020, we could find a hypodense calcified lesion appended by a cyst with a dot sign located at the gray-white matter junction at left parietal region, which supports colloidal vesicular states of NCC. We could see from the axial view. Now from the sagittal view, we still could see the cyst with a dot sign at the parietal region. So it concluded that this is a colloidal vesicular states of NCC. And the possible differential diagnoses are cerebral metastasis, pyogenic cerebral abscess or amoebic encephalitis. And calvera and parallel sinus is still appear normal. By the anamnesis and physical examination, and also from the neuroimaging, we diagnose this patient with neurocysticercosis. So we give the anti-parasitic in combination with anticonvulsant and anti-inflammation. The anti-parasitic, we gave albendazole 400 mg twice a day, orally for a month, and for anticonvulsant, we gave valproic acid with a dosage of 15 mg per kilogram per day, orally for a month. And for anti-inflammation, we gave dexamethasone 1 mg per kilogram and maximum dose 12 mg 4 times a day intravenously for a day in this patient. We gave it in hospital. After a month of albendazole and valproic acid administration, the patient neither had any seizure or other complaints. And the CT scan evaluation as described below. So the left one is before treatment and the right one is after a month of treatment. We still could see the hypodense lesion, but there's decrease of edema and calcification is also decreased. So in general, we could conclude there's a radiological improvement in comparison with the previous test. So the albendazole 400 mg orally still given twice a day for 1 more week, and valproic acid 15 mg per kilogram per day for another 2 years. And the next CT scan evaluation will be administered after 1 year of therapy. This is very important, so the patient and her family were educated to prepare any type of meat until it is perfectly cooked in order to avoid the parasitic infection, especially cysticercosis. They are educated to do a monthly follow-up to pediatrician at Waingapu Hospital or when seizure occurred. For the discussion, so from here, we could see that neurocysticercosis has been identified as the commonest parasitic infection of the central nervous system. And this case report discovered the most prevalent clinical manifestation of NCC, namely seizure. The studies proven that seizure as the most frequent clinical manifestation. Neurocysticercosis has been discovered as the most common cause of focal seizure without generalization. And especially in our region, Southeast Asia region, this case is considerably high. And for the life cycle, so the classic life cycle of Teniosolium consists of two types of hosts: human as a definitive host and swine as an intermediate host. Individuals who consume undercooked pork meat containing cysticerci will allow larvae to grow into adult tapeworm in the human's intestine. The adult tapeworm produces daily eggs which would be spread to the environment via feces. Therefore, in that condition, human acts as a definitive host. If the place have a poor hygiene and sanitation, then there might be a chance for roaming swine to consume food which is infected by eggs. Then the life cycle in the intermediate host will begin. Eggs will develop into oncosphere, and by the impact of gastric and pancreatic enzyme, by using their hooklets, oncosphere will cross the intestinal wall, enter the bloodstream, and be delivered into various internal organs, such as brain, muscle, eye, subcutaneous tissue, etc. In the case of NCC, there is a disruption in the classic life cycle of Teniosolium, which is caused by individuals who inadvertently consume food or water contaminated by eggs. The parasite identifies human as an intermediate host, and they will be carried in the systemic circulation, which lead the migration of the parasite into the various internal organs, including the central nervous system. In this patient, we discovered that she had a history of eating pork in the rural area of central Sumba. It is known that the method most people use to eat pork is not fully cooked, along with poor sanitation and hygiene. Hence, it might lead to the possibilities of Teniosolium infection in this patient. So the NCC stage divides into 4 stages: vesicular stage, colloidal vesicular stage, granular nodular stage, and nodular calcified stage. Now we describe one by one. So the vesicular stage, we could see a cyst with a dot sign, and the density is more like cerebrospinal fluid. And from the T1, we could see the eccentric hyperintense scolex can sometimes be seen, and no enhancement is typical. Very faint enhancement of the wall and enhancement of the scolex may be seen. And we should note that there's no surrounding vasogenic edema in this stage. And colloidal vesicular stage, like in this case, so we could see the cyst fluid become turbid, reflected in altered imaging appearance. So in CT, hyperattenuating to CSF, if MRI, hyperintense to CSF. And the most important one is we could see a surrounding edema. Like in our case, we see the edema also. And the cyst and the wall become thickened and brightly enhanced. This is also be seen in our case. And the scolex is seen early, but it could be shrinks. In our case, we could not see the scolex. And the next one is granular nodular stage. The edema decrease, like we could see from here, and the cysts start to retract and become very small, but the enhancement varies, but is less marked. And the last one is nodular calcified stage. It is best visualized by CT scan, as We know that calcification is easily be seen in CT scan, and this is the end-stage quiescent calcified nodule. And we should note that there's no more edema in this stage. This is our case report. We could see the surrounding edema. We could see the cyst with a dot sign. It's really could be seen as the colloidal vesicular stage. The treatment for this patient, as we mentioned before, first it's anti-parasitic. Albendazole as the drug of choice in the treatment for viable intraparenchymal brain cysts. And it has been proven by its effectiveness to pass through the blood-brain barrier. The dosage is 15 mg per kilogram per day, divided into 2 doses, consumed after meal, and the duration is a month. Albendazole is less expensive, safer, and better penetration to subarachnoid space in comparison to praziquantel. And by the Infectious Disease Society of America, IDSA, and the American Society of Tropical Medicine and Hygiene, ASTMH 2017, it stated that albendazole as a single antiparasitic treatment for 10 to 14 days was recommended for patients who suffer 1 or 2 parenchymal cysticerci. For the combination therapy, albendazole and praziquantel, they were used if the cysticerci is more than 2. In this case report, as the patient suffered 1 viable intraparenchymal NCC, so we give albendazole monotherapy in 2 divided doses for 1 month. And for the corticosteroids, it has been proven to be effective for overcoming local edema and inflammation, which is induced by the destruction of parasites by the application of anti-parasitic drugs. And steroid has also been proven to have the capability to increase the plasma content of albendazole, which are not appeared at praziquantel groups. And by the IDSA and ASTMH 2017, it has been affirmed that steroid as the adjunctive therapy for NCC. However, the dosage is still unclear, so one study could use the IV dexamethasone 6 mg per day, and another study using the oral prednisolone, and another one using a single dose of steroids, dexamethasone 10 mg. And so in our case report, we use the intravenous dexamethasone administered with a dosage of 1 mg per kilogram per day, maximum dose 12 mg per 6 hours for a day, which was given in hospital. And for the anti-epileptic, so in general, most patients who suffer seizure from secondary to NCC respond well with monotherapy of first-line anti-epileptic drug AED like carbamazepine, valproate, and phenytoin. So as in Sumba Island, the available of first-line anti-epileptic drug is only valproate, so we use valproic acid. And the duration, according to Garcia et al., explained that NCC patients who suffer seizure use the AED for duration of 2 years after the last seizure, and we have to do a tapering off. Our treatment regimen is accordance with the clinical practice guidelines by the IDSA and ISMTH 2017. Valproic acid we use for 2 years, and dosage 15 mg per kilogram per day orally. Moreover, by the lack of control data, then option of AED should be based on local availability. So we use the valproic acid. And to summarize, this patient will be done the CT scan evaluation 1 year subsequently by the initial seizure to evaluate the cystic lesion. And the electroencephalograph is not performed in this patient as it's not available yet at Sumba Island. And the most important one, education about sanitation and hygiene, is one of the most noteworthy prevention plan for this patient and also for the community, as neurocysticercosis is highly preventable disease. For the take-home message, neurocysticercosis is a CNS infection caused by Taeniosolium tapeworm cyst, and the current evidence have revealed that NCC is one of the most frequent causes of seizure among children and adolescents. Poor hygiene and sanitation are the important epidemiological factors that trigger this disease. Although neurocysticercosis has a wide clinical spectrum, seizure has been proven to be the most common clinical manifestation. And as we know that the clinical manifestations were atypical, so neuroimaging is very essential tools in order to diagnose NCC. And the management of NCC consists of anti-parasitic drug in combination with other supportive therapy, and the collaboration between public health and other multidisciplinary sector is the key to eradicate this disease. Thank you very much for your attention. If you have any question, please kindly email this email below. Thank you so much. Thank you very much for your attention. I hope this presentation brings us a light about knowledge of neurocysticercosis and enhance our awareness in tropical infectious disease. Thank you.